everyone. I'm Robert Kersner, Harvey Brank Professor and Chair of Dermatology at the Dr. Philip Frost Department of Dermatology and Cutaneous Surgery at the University of Miami Miller School of Medicine. And today we have a session entitled The Correlation Between Early and Aggressive Debridement and Skin Substitute Utilization on Healing Rates. This session is supported by an educational grant from Organogenesis. I'm joined today by Paula Pons, Medical Director at the St. Joseph Hospital Center for Wound Care and Hypopathic Medicine in Manlius, New York. And we have a great session planned for you today. By way of disclosures, they're listed here for myself and Dr. Pons. And over the next 45 minutes or so, we're going to try to meet these learning objectives, that the learner can recognize the importance of proactive, early, and aggressive wound management, beginning with debridement, as the first step to advance chronic wounds towards healing. To examine data for the use of early advanced therapy and skin substitutes for wound healing, and then explore via cases improved outcomes from implementation of an early and aggressive debridement and skin substitute use protocol. So I'm going to start off with this session, and then I'll have Dr. Pons show some cases after I speak. And I'm going to talk about proactive, early, and aggressive wound management. So we're going to start with the question, why do we debride? And really, debridement is part of the standard care for chronic wounds. And the chronic wounds we often see in the outpatient clinics include venous leg ulcers and diabetic foot ulcers. And certainly compression is part of the standard care for venous leg ulcers, and offloading is the standard of care for diabetic foot ulcers. But in addition to that, critical to standard of care is the use of debridement and, of course, infection management. And what we know that over time, that if a patient is doing the standard of care and the wound is improving, then we continue that standard of care. However, if the patient is not improving, and usually we assess this over approximately a 4-week period of time, then we certainly continue that standard of care. But at that point, we want to add adjunctive care. And I'm going to show you data of the importance of debridement and rationale for the use of debridement. But I'm also going to talk about how critical it is to move on to adjunctive care as soon as possible if the wound is not healing, because data suggests that the sooner you move on to adjunctive care, the better patient outcomes. And some of this work and this kind of global concept was presented in New England Journal of Medicine article that I was fortunate enough to be a co-author on. So what are the benefits of debridement? Well, certainly, first and foremost, if we do see necrotic tissue, we want to remove that necrotic tissue. We've expanded that idea to not just necrotic tissue, but unhealthy or non-viable tissue as well. Within a wound, and the longer the wound has been there, the more this is likely to be true, is that the cells, both in the wound and around the wound, change over time, and they become less responsive. People have used the term senescent for these cells, the fibroblasts in the wound bed and keratinocytes at the wound edge. But these cells are changed, altered, and they do not respond as they should. So it's important to think about removing those cells that are less responsive. We'll talk more about that in a few moments. So really, these two things together really talk about the idea of removing non-viable tissue, the removal of necrotic and unhealthy tissue, and the removal of senescent cells is really the removal of non-viable tissue. Furthermore, there's also the bacteria that all chronic wounds have colonizing them. Even in the absence of a frank infection, bacteria in the wound are problematic. And debridement certainly reduces the bacterial number, reduces the types of bacteria, and also helps to get rid of biofilm, which has been shown to be important in the chronicity of chronic wounds. And by doing this, not only does it set up the wound to heal, but also reduces the risk of more serious infection. And in certain situations, such as diabetic foot ulcers, the risk of infection can be something that tips a patient over to the need to have amputation. And when you remove these necrotic tissue, when you reduce bacteria, as a consequence, you change the microenvironment of the wound, you reduce the inflammation, and inflammation drives proteases. So by debridement, you improve the environment of the wound, reducing inflammation and changing this proteolytic environment to a healthier environment for healing. So that's the rationale and the potential for debridement. Now, when you look at this picture, I think all of us would say that the superior aspect of this wound needs to be debrided. So debriding it and removing that necrotic tissue is critical to carrying on good wound care in this patient. So if your mission was to remove necrotic tissue, then removing it would have accomplished your mission. Here's another example. This turns out to be an atypical wound. This is the upper back of somebody with lupus. And you could see they had that big necrotic escar. The goal of debridement here was to remove that necrotic escar. I did so. And she was left with a wound that was now free of necrotic tissue. So if my outcome was the removal of necrotic tissue, I succeeded in doing it by performing this procedure, and mission was accomplished. But in addition to just that visual satisfaction, that visual outcome of removing necrotic tissue, there are other things that are going on, and I highlighted them a little bit a few moments ago. And the fact, one of them is the changing of cells in the wound bed and the wound edge. And let me talk about the wound bed to start. And the cells we're talking about here are the fibroblasts. And here you see two photomicrographs. One on the left is cells from a chronic wound, and one on the right is cells from fibroblasts from an acute wound. Now I'm going to talk about the cells on the right first, the acute wound. If you take cells in culture and fibroblasts from an acute wound and put them in culture, they grow like the dickens. They grow, they're healthy, and they populate a petri dish in culture very, very rapidly. On the other hand, if you take fibroblasts from a chronic wound and place them in culture, they don't grow, they don't populate. In fact, they elongate, they're stressed, they don't fill the full dish. So you can see here in culture, these cells are abnormal taken from a chronic wound. They're much different, their characteristics are different, and they behave differently. One example of how they behave differently is if you try to stimulate those cells, those fibroblasts, with something that normally makes fibroblasts proliferate. And in this case, platelet-derived growth factor is used to stimulate the growth of fibroblasts. And there are three sets of fibroblasts that in this graph is demonstrating. The one is just fibroblasts from dermis. So a biopsy is taken from a normal skin, and the fibroblasts are taken from the dermis. The second is fibroblasts taken from an acute wound, and then fibroblasts taken from chronic wounds. And what happens is if you put them in a petri dish and then stimulate them with PDGF, the fibroblasts from acute wounds and from normal dermis grow like the dickens and increase over time. But if you look at the chronic wounds, they do not grow as well. And there's a significant difference in response to typical stimulatory growth factors. So these fibroblasts are abnormal. They look abnormal in culture. They don't grow as well, and they're not stimulated in the normal ways fibroblasts are typically stimulated. Now, we also know about bacteria in wounds, and one of the things that we don't see visibly or readily are both bacteria and biofilms. We envision they're there, but we do know certain things about biofilms that we've learned over the last 20 or so years in wound care. And we know that biofilms have two important characteristics. The first one is that they're firmly attached. And the second characteristic is that they're resistant to typical antimicrobial agents. So if you treat them with antibiotics, topical or systemic, they don't go away. And if you just try to wash them away or wipe them away, they don't go away because they're so firmly attached. These are two important characteristics. And that's why there's a critical need for real, significant, and aggressive debridement in these wounds so that you can remove the biofilms that are present in chronic wounds. And here's an example of different ways to remove biofilm from chronic wounds. And you see that there's a non-inoculated wound that has a low number of bacteria, but then when you inoculate a wound, let a biofilm form and then either use pulse lavage or even a simple curette, you don't significantly reduce the numbers of biofilm bacteria that are present in the wound. And this is done, in this case, in experimental wounds. But this happens in typical venous leg ulcers and diabetic foot ulcers as well. So a simple curette placed across the wound is not the answer to removing biofilm. You need to have aggressive debridement with a scalpel to really get below and around the biofilm that is formed in that wound, because it is tightly adherent. Now, I talked a little bit about the cells, the fibroblasts in the wound bed and the bacteria in the wound bed, but now I'm going to talk a little bit about the cells at the edge and talk about the keratinocytes that surround a chronic wound. This is a chronic diabetic foot ulcer. And the question is, what do you debride? And this slide reminds you that when you're thinking about debridement, you're not just debriding the wound bed, but you want to debride the wound edge. And I'm going to share with you some experimental data to prove to you that debriding the wound edge is critical to the success when you're considering debridement. So this is a chronic wound, in this case, a venous leg ulcer. And you can see that right next to the wound, we call location A. And a little bit adjacent to it is location B. And then on the third panel, there's photomicrographs of normal skin. And what you can see, that location A is hyperproliferative, it's inflammatory and fibrotic. And as you move away from the wound edge, the skin changes, the histology of the skin changes and begins to look a little bit more like normal skin, where it's not hyperproliferative, it's not inflammatory, and it's not fibrotic. And you really want to get to location B, to more healthier skin when you're debriding the wound. So that's why it's critically important to debride the wound edge. So you want to get that hyperproliferative, callous, thickened, non-migratory epithelium and get to healthier epithelium. And we showed this not just histologically, but using gene expression profiles, that you can debride away a negative gene expression profile, that is location A. And if you successfully debride, you can change the gene expression profile and get to location B, where the gene expression profile is similar to normal skin and able to heal a wound, migrate, and reepithelialize a wound. Now, we've done a significant amount of work in this. In fact, Mariana Tomic in our department has really championed this and really led the efforts to understand the edge epithelium of chronic wounds. And you see, typically in acute wounds, you have a migrating tongue of epithelium, you have a lot of cytokines and growth factors, but this cartoon depicts that in a chronic non-healing wound, you don't have a migrating tongue of epithelium, you have hyperproliferative, non-migratory edges of that chronic wound. And that chronic wound also expresses some negative biomarkers, some negative factors, including c-Myc and nuclear expression of a protein beta-catenin. And this cartoon and a picture of Dr. Tomic here shows you that the healing skin does not have c-Myc or nuclear expression of beta-catenin, but when you begin to have that expression, it now is a non-healing phenotype that is expressed because of c-Myc and beta-catenin. Now, as I mentioned, there's been a lot of work in this area, and it turns out that c-Myc, when it's present, drives the loss of epidermal stem cells that are normally found at the edge. So at the edge of that chronic wound, that location A, you see very, very few epidermal stem cells that would normally be highlighted by this keratin 15 stain. If you look at location B, a little farther away, meaning that you went away from the edge into more normal skin, now you see the green staining of epidermal stem cells, which is actually very similar and even a little bit more than the staining in normal skin. Now, looking at beta-catenin, because in one hand, it's in the nucleus, so the cell looks completely opaque, and in the other, it's in the cytoplasm where the nucleus is clear, so it has like a halo look. You see here on the left, the cells are completely opaque. They have nuclear expression of beta-catenin, which is a healing incompetent or non-healing presentation. But if you had a molecular scalpel, you could cut away right where it changes and get to healing competent tissue. And that's really the point of debriding the edge. You want to get to the healing competent tissue so the wound can, in fact, have a chance to heal. And we've studied this. We have ongoing NIH-funded studies looking at this idea in the debridement of venous leg ulcers. So in fact, we've even proposed this idea of a Mohs surgery to remove or debride wound edge. So similar to Mohs surgery, what typically you do in Mohs surgery is you excise a cancer and then look to see if you successfully removed the cancer cells. In a similar fashion, one might imagine you would debride and then look at the cells under the microscope and see if you've gotten to that location B, the healthier cells. And if you did, great, you could go on and do your wound care, including, as I will describe in a little bit later, the use of skin substitutes. Or if you didn't, you might want to go back and debride better. Since we don't have this Mohs surgery currently for debridement, that's why it's critical to do aggressive debridement for these wounds, including both the wound bed and the wound edge. So here's a picture of kind of putting it together. You want to debride the wound bed here, and this was painted with this gentian violet, so it has a purple color. But again, you want to then go beyond that wound edge, but beyond the edge of the wound bed into the normal skin to get to location B, so that you can successfully debride and accomplish those things that you were trying to accomplish with debridement. So that's the rationale for debridement. What's the evidence for debridement? Well, the evidence for debridement starts with this very famous study when platelet-derived growth factor, betacatenin, was being investigated and eventually approved by the FDA. A secondary analysis was performed, and what they found was whether the patients got placebo gel or the active betacatenin gel, patients who were debrided more frequently, or I would say office visits where debridement was performed more frequently, those patients healed to a greater extent. Now, this was not the definitive study for debridement for diabetic foot ulcers, because what was studied here was not necessarily an individual patient getting debridement, but really this is what we call an ecologic study, which is really hypothesis generating, because that famous study by Steed, debridement of patients wasn't what was looked at in the analysis. It was how much debridement occurred at each wound center. The centers that debrided a lot had better outcomes, but it wasn't necessarily the patient at a patient level evaluation. So patients who attended wound centers that debrided more had better outcomes. And the question arises is that those centers that debrided more, were they doing a lot of things better? And was debridement really just a marker of better overall care at the wound center? And this is a real challenge, getting good data for debridement. I showed you great rationale, scientific rationale and theory of why you should debride. But now we're talking about evidence, and evidence is challenging when it comes to debridement. One source of evidence comes from the engineered skin trial, where investigators, after the study was completed, they went and looked at pictures, and they looked at the callus, whether there was the edges had undermining or whether it was necrotic tissue, and then they put this scoring system of these three categories, and And what they suggested was whether a wound needed debridement and was carried out, whether it needed debridement and it wasn't carried out, or whether it didn't need debridement. And they called this a debridement performance index. And what they found was that when there was a high debridement performance index, patients did better with the application of engineered skin, but also in the control group as well. Now, you can see here that there were 3 categories, and each category got a score of 0 to 2. If they got 0 points, if debridement was not needed and was needed and not done, 1 point if debridement was needed and it was done, and then 2 points if debridement was not needed, that the wound looked healthy and didn't need to be debrided. And what they found was that if they using the scoring system, was that if you had a higher debridement performance index, you had better healing of chronic wounds. And if you had a lower debridement index, you had a lower healing. So if you needed debridement and it didn't get done, then wounds did not do as well. And that kind of makes sense to what we think. Now, a study that was on diabetic foot ulcers and venous leg ulcers, the best study is this concurrently controlled cohort study. And what that means, it wasn't a randomized controlled trial. What happened was patients went into the clinic and the doctor looked at the patient and said, you need debridement or you don't. And those that needed debridement got debridement. But what was interesting is that the patients who needed debridement and received the debridement did better than the group of patients that were thought not to need debridement. And this suggests that we're really not so good at understanding who really needs debridement. Because if you debride a wound, it actually turns out it's better than a wound that you don't think needs debridement. And this speaks to the idea of early aggressive debridement for chronic wounds. And this was a statistically significant difference when patients got debridement compared to the group that wasn't even thought to need debridement and didn't get it. Now, this next study involves small intestine submucosa, SIS. This was a randomized controlled trial that studied this product. This was venous leg ulcers, and they had to have, these were non-healing wounds, but they did have some degree of granulation tissue. More than 50% of the wounds had to have granulation tissue. And this was the study, but what I wanted to highlight here was the group that got standard excuse me, let's go back for 1 second here. First, I want to look at the extracellular matrix that was applied, and you could see that there was improved healing if patients got debrided compared to those that didn't get debrided. But then I want to look at the standard of care for a second. And this really talks about the idea that oftentimes debridement alone isn't the answer. So while you want to do all these things to help a wound heal as part of your standard of care, debride the wound bed, debride the wound edge, but that always doesn't lead to healing. And you can see here for these venous leg ulcers, only 30% of patients who were debrided eventually healed. So oftentimes, as we know, patients need more than just debridement. So again, I shared with you the idea of why you might debride, removing necrotic tissue, removing senescent cells, reducing bacteria, and also reducing the inflammatory and proteolytic environment. But also, importantly, debridement allows for preparation of advanced modalities. So now I'm going to transition from going from early aggressive debridement to early use of advanced modalities, and in this case, skin substitutes. So when would you use adjuvant therapy? And I'm going to show you data for that. Okay. This was a study we published about 10 years ago in the Archives of Dermatology, which is now JAMA Dermatology. And this was a real life study of patients who had received advanced biologic therapies. At that time, the three most common advanced biologic therapies was platelet-derived growth factor, the bilayered living skin construct aplograft, and platelet releasate. This was a real world study of 2,500 patients with 9,300 wounds. And when we looked at the analysis, we found several things being critically important to good outcomes. These included the wound size, the wound duration, and the wound grade, how severe this diabetic foot ulcers were. But importantly, what we found for all advanced therapies, including skin substitutes, that the earlier you applied the skin substitute, the better the outcomes. And this was controlling for all other factors. It was statistically significant. So if you applied the skin substitute at 4 weeks, as opposed to 6 or 8 or longer, you had better outcomes. That's why it's critical that you move on to advanced therapies as soon as you recognize that wound is not making progress. Now, in this study, other things came shown to be important, and I'm going to share with you which all of the products worked, but the product that worked best was the bilayer living cellular construct here. And here you see the data. In the darker line is the bilayer living construct aplograft, and then the other two lines are the platelet releasate curin and the platelet-derived growth factor, or Granex. And what we found was that when you received the bilayered living cell therapy, patients were about 31% more likely to heal than if they received the recombinant growth factor therapy, and they were 40% more likely to heal than if they received platelet releasate. This was a Kaplan-Meier or survival curve, and of course, the bottom line is better because there's less survival of the wound. We did other analysis that demonstrated a similar finding, that the bilayered living cellular construct had better healing than the other two products. But it does speak to the idea that early use of products. Now, it turns out that early use of products is not just for the bilayered living skin equivalent. This is a analysis of patients. This was a single arm analysis of patient using bioactive human split thickness skin allograft for the treatment of venous leg ulcers. And what this was another real life study of 862 ulcers and 742 patients with venous leg ulcers. And this subset of patients who all received a split thickness skin allograft, and a number of factors were analyzed. But critically important was the early application of the product. And in this case, the cutoff was 90 days. But if they received this product early on within the first, before 90 days, they were 40% more likely to heal than if the application of this product was delayed. Again, speaking to the idea that skin substitute products work better if they're applied earlier for patients with chronic wounds like diabetic foot ulcers and venous leg ulcers. And this paper also suggested that clinicians should consider more aggressive and earlier timely treatment for refractory venous leg ulcers. So I'm going to stop here and going to hand over the presentation to Dr. Pons, and I'm just summarizing by saying that debridement is the cornerstone of great wound care, that simple debridement and debridement of the wound bed only is not what we're talking about of great debridement. We're talking about aggressive debridement and debridement of both the wound bed and the wound edge. And not only will that put the wound in the best position to heal, but it's also part of the planning process for the use of advanced therapies. And when you see that a wound is not responding to standard of care, it's critical to move on to advanced therapies early on, because patients experience the better outcomes if they're treated earlier with advanced therapies. So with that, I'll stop, and it's a pleasure to introduce Dr. Paula Pons.
Thank you, Dr. Kirchner, for your presentation. I will now share with you 3 cases in which aggressive debridement and early utilization of skin substitutes improved and accelerated healing. The first case that I want to share with you is that of a 83-year-old gentleman who was referred to our wound center with a first metatarsal head ulceration from diabetes. He had well-controlled type 2 insulin-dependent diabetes mellitus and was a former smoker. 2 months before he presented to our wound center, he had undergone left hallux valgus osteotomy. After the surgery, he developed a wound infection and the surgical wound dehisced, and he was diagnosed with acute osteomyelitis. He was hospitalized and treated with IV antibiotics, and while in the hospital, he was evaluated by vascular surgery and was found to have arterial disease requiring angioplasty. When he presented to our wound center, the wound had still bone exposed. The patient had already completed a 6-week course of systemic antibiotics, and we started treating him with very aggressive initial debridement on the first visit, including bone debridement. He was seen at the wound center on a weekly basis and underwent frequent debridements to remove any of the non-viable tissue as well as address the biofilm. Early in the course of the treatment, we used purified collagen matrix with PHMB to help manage biofilm between debridements. And once the wound was cleaned and granulating, we continued with frequent debridements and decided to start human fibroblast-derived dermal substitute to heal the wound. All along, the patient underwent hyperbaric oxygen treatment as an adjunctive therapy to help heal this Wagner 3 diabetic foot ulcer. Now I'm going to show you some of the photographs of his wound. The first one on the left side of the screen is the day of presentation to the wound center. As you can see, the part of the metatarsal was exposed, and you can even see the osteotomy line right there in the middle of the wound. That bone was pretty dry and non-viable, really, at least at the surface of the bone. And there was a lot of slough and biofilm at the base and edges of the wound that needed to be addressed. The photograph on the right is a month later, and all along from the first visit to a month later, we were aggressively debriding the wound and using this extracellular matrix with the PHMB to help control the biofilm and decrease the inflammation. And you can see that, now bone is no longer exposed, and we have somewhat a contracted wound that is less inflamed. Now, at this point in time, let me go back to the previous slide, actually. At this point in time, a month into aggressive debridement and getting rid of all that non-viable tissue and biofilm, as well as the early use of that purified collagen matrix with PHMB, we decided to move into a more advanced wound treatment and continue debriding aggressively, but also switch the use to a human fibroblast-derived dermal substitute. And it was about a month ago when we did the switch, and you can see the results on this following slide, where the photo on the left shows how the wound in 4 more weeks has significantly reduced in size. The healing has progressed significantly. There's no longer bone exposed, and 12 weeks after the initial evaluation, he is completely healed. Now, the next case I want to share with you is a 55-year-old male that presented to our wound center with a right venous ulcer. He worked as a chef and was on his feet all day. He had varicose veins and was wearing no compression and had quite a great deal of edema on both legs. When he first presented to our wound center, we evaluated his arterial status with an ABI that was normal with triphasic waveforms. And we proceeded with aggressive initial debridement and started him on a 4-layer compression wrap. During this time, he was also referred to vascular surgery and was diagnosed with venous reflux and eventually underwent vein ablation to address that reflux. He continued coming to the wound center where he had frequent debridements. He was coming pretty much weekly. And, debridements were guided to removing non-viable tissue and addressing biofilm. We started early use of bilayer cellular construct to heal the wound. And we did weekly applications of this construct also. And we'll continue weekly high-grade compression wraps on this patient to address his edema. Once he was healed, he was prescribed lifelong use of compression stockings to prevent the swelling from coming back and having more of these ulcerations. So here also you can see his photographs. The one on the left is on the first visit to our wound center. You can see it's a quite significant size of the ulceration, typical vein leg ulcer with a lot of drainage, a lot of slough, inflamed, large amount of biofilm. And you can see also in the surrounding skin, the presence of edema. The skin is shiny and tense, and this needed to be addressed as well. In the photograph on the right, we had undergone already several aggressive debridements, getting rid of all those senescent cells and addressing the edge of the wounds, as well as getting rid of biofilm. And you can see how the looks of the wound have definitely changed. There's more granulation tissue, but also the skin around the ulceration has changed significantly. It's not as shiny, not as tense. Definitely we're gaining control of the swelling with the compression wraps. And it's at this point where we decided to start with bilayer cellular product. We did a series of 5 applications of the skin substitute. And you can see here on the photo on the left, the ulcer is nearly healed, significant reduction of the size of the ulceration. And this is a result of the aggressive debridement and the early use of the bilayer cellular construct, as well as a very aggressive compression therapy to get rid of that swelling. You can see how the skin is wrinkly now on the leg. And eventually at 15 weeks after presentation, you can see the photo on the right where the ulceration is completely healed. And as I mentioned before, this patient was discharged on lifelong compression therapy to continue addressing his swelling and hopefully preventing further ulcerations. All right, the last case I want to talk to you about is a 50-year-old lady who presented to our wound center with a Wagner 3 diabetic foot ulceration with a deep abscess. She had poorly controlled type 2 insulin-dependent diabetes mellitus and had previously been hospitalized for an abscess, for this abscess that required drainage, aggressive debridement in the operating room, and systemic antibiotic therapy. While she was in the hospital, she underwent revascularization via angioplasty and stent placement. She had arterial disease in both her anterior tibial and posterior tibial arteries on that leg. Once she presented to the wound center, she underwent frequent serial debridements to get rid of all non-viable tissue and address the biofilm. And we started her on a total contact cast to relieve the pressure from the ulceration. This allowed her to continue to ambulate and at the same time protect the wound by relieving pressure from it. We started with the early application of human fibroblast-derived dermal substitute. We completed 8 applications of that skin substitute to heal the ulcer. Simultaneously, she had adjunctive hyperbaric oxygen treatment to help treat this Wagner 3 diabetic ulcer. And during all the time that she was coming to the wound center, she also was working with a nutritionist to get her diabetes under control. And by the time she was discharged from the center, she had a hemoglobin A1C of 7.1, down from 8.3 when we first admitted her. And here are her photographs. You can see on the day of presentation on the photograph on the left, a very large, very bad-looking diabetic foot ulcer. There was some necrotic tissue, a lot of callus. You can see that there's still a lot of inflammation from that abscess that had been drained, and there's still a lot of work to do to get that healing, really. You can see on the photo on the right, about, I would say, 6 weeks later, that after very aggressive debridement, the wound responded very well. And now we have a better looking wound base. There's no almost callus around the wound, and that is because we are not only addressing the wound edges and the callus with aggressive debridement, but also the fact that we were able to relieve pressure with a total contact cast. At this point, when we had resolved the inflammation and gotten the biofilm under control, was when we decided to start advanced wound therapy with a skin substitute, and chose to use human fibroblast-derived dermal substitute for her wound. And you can see here the progression of healing. The photograph on the left already shows very significant reduction on the size of the ulceration, and it has also filled in from the base of the wound. We continue with weekly aggressive debridement and weekly application of the skin substitute. And you can see that it continues to get smaller. And after 21 weeks of aggressive treatment, we were able to completely heal her ulceration. So the take-home message really is that frequent visits, hopefully weekly visits, together with aggressive debridement and the early use of advanced modalities, including the early use of skin substitutes, will result on increased healing rates, as well as decrease time to heal in both our diabetic foot ulcers and vein leg ulcers. And with that, I thank you very much. Thank you, Dr. Kirschner, for your presentation. And we will entertain questions.
Well, thank you everyone for joining this session of the SAWC. I'm joined in the live Q&A by Dr. Paula Pons, and we're going to try to answer as many of the questions we possibly can over the next 15 minutes or so. And the questions are coming in, a lot of great questions. Keep them coming and we'll do the best we can to answer them. So we're going to kind of both take shots at these questions depending on our area of interest or talk or expertise. So the first question I'd like to, that was posed to us, Paul, is that weekly debridement is the question, the person's asking the question, is their default. And they really want to know when not to debride. And they want us to talk about pyoderma. We really can't really do anything, can we? So Paul, do you want to take this question, or would you prefer I do?
Sure. Thank you, Rob. It is an interesting question, and you know, we all come across pyoderma at one point or another in our practices, right? And traditionally, we know that we should not debride pyoderma to avoid that pathology of making the wound worse as we debrided. Now, as you know, pyoderma is an autoimmune disease and needs to be treated as such. So making sure that we get the immune system of the patient under control with steroids and more complex immunosuppressants, it is important. So we need to address that with systemic immunosuppressants as well as topical immunosuppressants. In many of those circumstances, we may be able to use debriding agents that can address some of that bioburden and biofilm without actually having to aggressively debride with a sharp tool. But I think it's very important to understand that once the autoimmune problem is under control, once we have gained control of the immune system attacking the tissues, at that point, it is okay to start debriding the wound and getting rid of that necrotic tissue and that bioburden and help that wound heal. It is kind of difficult to realize when we have crossed that bridge. There's some publications about that. But that's what I do in my practice. Once I have the immune system under control and we don't see as much of that inflammation going on, I go ahead and start debriding my patients. How about you, Rob?
Yeah, so I think I agree with you 100%. Conventional wisdom has taught us that we shouldn't debride pyoderma gangrenosum, but there's been a host of literature suggesting that not only could you debride, even perform some flaps and even if the inflammation's under control, if you have them on anti-inflammatory immunosuppressive medication. So in this case, the first idea is to get that inflammation under control, and then you can consider debridement. I also think that the other major reason why we don't debride is because of poor arterial blood supply, and that's a major issue that, again, we'd prefer to correct. Because if you debride someone who has poor blood supply, then the escar will probably reform. All that is probably, with every rule, there's an exception. And of course, if you're dealing with an acute infection and you're really trying to debride the infection, sometimes we ignore that rule of having good blood supply just to clean out the wound. So I think there are certain situations where we don't debride. And of course, then there are patient characteristics, our ability to have pain management and get good anesthesia, and our ability to get hemostasis may obviate our ability to do a debridement in the clinic as opposed to being in a more controlled setting. But fantastic, great answer. Thank you, Paula. Let's move on to the next question. And it's really about debridement and how debridement might work. The question states, you stated earlier that debridement decreases inflammation in the wound. And I thought debridement was used to stimulate a stalled wound to reinitiate the acute inflammatory phase. Can you please elaborate? Paula, do you want to take this, or would you like me to?
Go ahead.
Yeah, so there's no question that debridement does a lot of things, and there's a lot of rationale for debridement. So if you have necrotic debris and you have bacteria in the wound, they are going to, as a consequence, create inflammatory cytokines and proteases that are going to be destructive to the wound. So by removing those, you'll remove the nidus for inflammation. So in fact, you do reduce a certain degree of inflammation. But remember, chronic wounds have one type of inflammation, chronic inflammation. And healing wounds or acute wounds have another type of inflammation, which is an acute inflammation. And what we've learned, a lot of this has been with some studies involving tissue engineered skin, and including the bilayer living cellular construct, that what we initially thought was that when you treat a chronic wound, you're supposed to shut off the inflammation. That is no longer true. And the combination of debridement and the use of a bilayer living cellular construct in well-done experimental studies has shown that it does change acute inflammation chronic inflammation to acute inflammation. So both things are true with debridement and the use of early skin substitutes. Let's move on to the next question. Should well-adhered dry black escar always be debrided from a wound base? Paula, do you have thoughts about this?
Yes, typically, when we have a firmly adherent dry eschar, that I think we all see that mostly on pressure wounds, we tend not to debride it. The idea is to keep it dry and allow the patient's own enzymes to start softening that tissue underneath and eventually lifting up that black eschar. And that's the sign for us to start the debridement. What I typically do is just use a dry dressing or keep it dry with skin prep or sometimes even betadine. But I don't tend to debride until I see signs of that eschar lifting. How about you, Rob?
Yeah, so this is a very interesting question because I think once again, a lot of us were taught that, especially on the heel, where if you have black escar, you don't want to remove it because of the concern that maybe the bone is so close to that escar that you'll increase the risk of osteomyelitis. And I think the wound community has gone a little bit back and forth of whether you should remove that black escar or not. And there's very little good data to drive our decision making. So I would say that conventional standard care is exactly how you described it. But I do think that's a topic that's probably worthy of study to see whether or not some of the things that we routinely do are in fact true. And they of course probably are, but it's always good to confirm those things and think about them. So yeah, I tend to be like you, but I also realize that perhaps what we do is out of habit as opposed to evidence. Our next question asks about, what about a big escar, a really large escar in a lupus patient? How would you debride it? And how would you anesthetize this wound prior to debridement? Paula, do you have any thoughts about this?
So I think this question concerns one of the patients that you presented on the recording. So if you want to take it.
Sure.
Go for it.
Yeah. So it turns out that that the most direct way to do a debridement is surgical debridement. It's fast and it's very efficient. That doesn't mean, but one of the downsides obviously is pain management, and that's why it's critical that we have good pain control prior to performing the debridement. So typically I would use local anesthetic, and there are some tricks so that local anesthetic is the least painful it possibly can. We often used a buffered solution because the acidity of the anesthetic, especially when lidocaines combine with epinephrine, is acidic, and acidic anesthesia is more painful when you inject. We put the needle in quickly, deliver the anesthesia slowly because people feel the needle going in and the spreading of the tissue. And then we advance, we activate C fibers by pinching or spreading the skin so that to reduce the pain of debridement. And then as we advance the needle, we always put the needle in where it's already anesthetized. And if you do that, you pretty efficiently can anesthetize a fairly large area within 3 to 5 minutes, and then allow for removal of the large escar. Moving on to the next question, a question asked about ischemic wounds. And are there any hard and fast rules about when we can debride ischemic wounds? Is it based on a ABI or a TBI, for example, a TBI of 0.3, or would you suggest we use a different form of debridement for ischemic patients? Paula, do you have any thoughts about this?
Well, you addressed some of that already with the first question, and ischemia is of course one of the reasons many times we don't debride, right? I don't think there's any fast rules on when not to debride debride in an ischemic area, generally ischemic limb. And it has a lot to do with the wound itself. And you mentioned before that having infection in that area would be one of the reasons to kind of forget about the ischemia and go for the debridement because we're trying to control the bioburden of the wound and fight the infection, even if the limb is ischemic. Do you have any fast rules or numbers?
No, I think that obviously I agree with you, and I think that I want to point out with this question and to remind people that we have a lot of tools to debride. Surgical debridement is probably most commonly used, at least in certain populations. We have chemical products like Santal, like was asked in this question, but we have other forms of debridement as well. We have larval debridement, we have autolytic debridement, mechanical debridement. We have hydrotherapy debridement. We have ultrasonic debridement. So I would try to remind people that not to narrow their view of how to accomplish a goal. And if there's a level of being uncomfortable with the surgical approach, well, then consider using other forms of debridement to accomplish what you'd like to accomplish. Another question relates to if you debride and the wound gets larger with sharp debridement, obviously beyond the extent of what you debrided. What does that mean? I'll just jump and answer this, and I would say that if a wound is getting larger with debridement, I think that's a time for reflection and asking yourself, okay, what's going on here? Am I missing something? Is there an ischemic component that's making it worse? Is this really pyoderma gangrenosum? Is the wound infected and getting larger because of that? So I think that that's really a point that that a astute clinician may go down one path to help a wound, but if they see the wound is not responding, to rethink the whole situation. Next question asks about debridement in patients on blood thinners such as Xarelto. What are your thoughts about this, Dr. Ponce? Would you like to take this? Or?
Sure. I think with blood thinners, of course, we always run the risk of increased bleeding. But really, the type of debridement that we do on a wound center, which is where I practice, and I rarely take anybody to the OR for debridement, the risk of getting into bleeding that we cannot stop at the center is quite rare. Usually is the bleeding at the base of the wound, and is more like an oozing than an active bleeding, and that with pressure, sometimes using a chemical to stop the bleeding. We can control that in the office setting without much problems. If it needs to be a more extensive debridement, like sometimes I see in large venous wounds or in large pressure wounds, I would rather take them to the operating room where we can control all the factors better. But I do not stop blood thinners for debridement on my patients, ever.
Yes, and in skin surgery, even beyond debridement, the risk of stopping blood thinners is higher than the risk of bleeding. So I agree with you completely. I think we just have time maybe for one more question, or maybe we just have a minute or so left. Do you have any thoughts about debridement for calciphylaxis wounds?
Yeah, I think the biggest problem we run into debridement on calciphylaxis is pain control. These patients are in extreme pain, and doing that is in the outpatient is a problem. If we're able to gain pain control with injectable anesthetics, I would debride them.
So I agree with you, and I think the time is getting close to the end, but I want to, first, I will let you have the final word in a moment, Dr. Pons, but I want to thank all the audience for both joining and asking some great questions. Dr. Pons, do you want to have some final comments and bring us to a conclusion?
Thank you. Thank you all for participating and for the excellent questions. We do encourage you to participate in the Passport to Prizes contest. Remember that the more you participate in, the more points you will earn. And we really look forward to being together again in person in Las Vegas in the SAWC in the fall. Thank you, everyone.